Just going to try and complement what Adenon has already mentioned earlier about dealing with KD3L injuries. First, we have to remember that most of the KD3L injuries that we are going to encounter are more from motor vehicular accidents. And there are only a few that we'll actually see from ball sports injuries like basketball or football. Only about 7% of them will present with this kind of an injury. So we're going to focus our attention on this, basically an injury to the ACL, the PCL, and the lateral collateral ligament, and most likely also some injuries to the posterolateral corner. Now, what makes the KD3L injury different from the KD3M are very salient features that we will only see in these kinds of injuries. First is a very high incidence of peroneal nerve injury. Second is that normally this peroneal nerve injury is even higher in patients who present with a posterolateral corner injury and rotational instability. And finally, the risk of a vascular injury is even higher in KD3L injuries compared to KD3M. And so these patients have to be monitored and managed acutely and assessed properly at the time of injury for any neurovascular injury. So a lot of these patients will definitely present with translational instability. They will present as well with, of course, the ACL and posterior cruciate ligament assessment will present with injuries. Then there's rotational instability, your pivot shift, mainly because of your ACL injury and the reverse pivot shift as well. And then checking for the posterolateral corner, of course, you will see that the dial test is positive. And sometimes these patients will have the dimple sign as well. When you take them into full extension, mainly because the tibia drops into external rotation, you'll see this dimple sign, which is a sign of posterolateral corner injury. Then knowing that the LCL is compromised, then of course, a lot of these patients, like one of the patients of mine, will present with a varus instability as well as a result of a tear of the LCL. So what's important for these patients is, aside from the standard radiographs, after these knees have been reduced, then of course an MRI, but more importantly, an angiogram should be done, especially if you've assessed these patients to have a potential for a vascular injury, after which you proceed with other imaging modalities to check the extent of the injury. So an injury to the ACL, an injury to the PCL, whether it's an avulsion or a tear of the mid-substance of the PCL, and also identify for any LCL or posterolateral corner injuries. Acutely, especially if your patients did present with a dislocation, then more often than not with this amount of instability, early or immediate temporary stabilization with an external fixator following the principles of damage control orthopedics may be applicable. But this does not, make sure this does not compromise your plan to do an acute repair of the collateral ligaments if that is your intention. So let's look at different scenarios. The first scenario is you have an acute dislocation with a vascular injury. Immediate reduction is important. Then you span this patient with an external fixator, plan for a delayed repair reconstruction, because the priority is the vascular injury. Now, if you have a patient with an acute dislocation but no vascular injury, then still span with an external fixator, do a primary repair of the collateral ligaments, then probably just plan for a delayed reconstruction of your cruciate ligaments, but monitor your vascular status in the process. In another situation where you have a patient with no dislocation but with a vascular injury, then the same, immobilize the patient with an external fixator, do a delayed repair, and prioritize your vascular repair. But our challenge has always been, if these patients are immobilized on an external fixator and you've done the repair of the collateral ligaments, then we might encounter a lot of arthrofibrosis. So what can be done that will not compromise the vascular repair or the collateral ligaments repair, but still allow for the lower incidence of arthrofibrosis? The solution is using an articulated spanning external fixator. Not all of us may have access to this, but probably our friends who do a lot of Ilizarov external fixation may be able to help us as well, because using a hinged or articulated spanning external fixator significantly reduces your tibiofemoral translation by 49% with the Lachman's test, 70% with the anterior drawer's test, or 46% with the posterior drawer's test, which means that your cruciate ligament reconstructions can definitely be delayed without compromise to your vascular repair or collateral ligament repair. So comparing repair versus reconstruction, like I mentioned earlier, you can probably do an acute repair in incidences where you have no dislocation and no vascular injury, then probably plan for your reconstruction 2 to 3 weeks later. Now, if you're dealing with lateral repairs, and of course, assuming it's just an avulsion from the femoral side or the tibial side or a mid-substance tear, you can just repair it primarily. The challenge happens when you have a posterolateral corner injury where an acute repair cannot be done. Then you may have to plan for a PLC reconstruction, An anatomic two-limbed reconstruction is actually recommended because this leads to a lesser incidence of residual posterolateral corner or external rotation instability. So this is how a PCL repair can be done as well if you have an avulsion or do a posterolateral posterior cruciate ligament reconstruction. So comparing early versus delayed reconstruction, this meta-analysis actually looked at early reconstructions that were done at a mean of 10.6 days and noticed that these patients had a 31% of these patients had normal knee kinematics, whereas for those who had a delayed reconstruction at a mean of 294 days, that's spanning basically almost a year already, only 15% of these patients had near normal sensation. But looking at range of motion, there was no significant difference between doing an early or a delayed reconstruction. Now, for the posterolateral corner reconstruction, an anatomic reconstruction is best because this actually significantly reduces the residual external rotation instability. And what's recommended is basically an anatomic two-tailed reconstruction because this provides the best varus stability, particularly with hyperextension, external rotation, and recurvatum. So how about the sequence of repair reconstruction? If you're doing a bicruciate reconstruction, for example, this particular journal looked at doing the PCL first, meaning tension of the PCL first, then fixation, compared to simultaneous tensioning of your ACL and PCL. What's actually recommended that eventually yielded better IKDC subjective scores and better functional scores was a simultaneous tensioning of both ACL and PCL, but fix your ACL first in extension, then fix your PCL on the tibial side in about 40 to 60 degrees of flexion. The one thing we should avoid, however, is tensioning the posterolateral corner first. The posterolateral corner reconstruction has to be tensioned and fixed last, because if you tension and tighten this first before doing your cruciate ligament tension and fixation, this might lead to severe internal rotation of your tibia. And with regard to the postoperative plan, of course, range of motion is delayed for around 2 to 4 weeks. The goal is to achieve full range of motion by about the 8th week after injury. And finally, just in a situation where you may be dealing with a residual peroneal nerve injury or chronic nerve lesion, then of course, if you have not reconstructed your ACL or collateral ligaments at this time, you may do so, but also consider doing a nerve graft or a tendon transfer. So in summary, when we're dealing with KD3L injuries, these are still multiligament injuries that present with multidirectional and multiplanar instability. But you have to remember that these particular patients are different from your KD3M because there's potential threat to the limb because of a vascular injury or a peroneal nerve injury as well. Aim for immediate repair of the collateral ligaments or probably even a cruciate ligament reconstruction whenever possible, but otherwise consider a delayed reconstruction of your cruciates. But then doing an acute repair of the collaterals or probably even your cruciate ligaments definitely yields better results compared to your chronic repairs or delayed reconstructions. Thank you very much.
Yeah,